Good afternoon, everyone. Today we're going to talk about fever of unknown origin, which I know you guys are all thrilled about when you get these cases out there, right? All right, so today's objectives are going to be to review the definition of FUO, to discuss the most common etiologies, and also look at the non-infectious causes of FUO. Of course, as an ID specialist, I get a lot of outpatient consults for FUO, so it is important to also look at the non-infectious causes. All right, so if we start with the definition, back in 1961 is when this entity was first described, and at that time, the criteria for it was for you to have a temperature of 38.3 degrees Celsius or 101 Fahrenheit for more than 3 weeks, with no etiology, despite 1 week of inpatient workup. Of course, this was in 1961, so you imagine that today you're not going to admit people to the hospital for a week for workup. Well, sometimes you do, but not necessarily today, because a lot of things we do outpatient. Then later on in 91, Durek and Street came out with a new definition and reclassified the FUOs according to etiology. So they kind of defined it and re-stratified it into 4 different groups. As you can see here, the classic, nosocomial, neutropenic, and HIV-associated. And they also changed the criteria to fever with no diagnosis after 3 outpatient visits with appropriate workup, or shortened it to 3-day inpatient workup. Okay? And this is just a table kind of outlining things that fall in the different categories. So like the classic, you see here infection, malignancy, collagen vascular disease. Nosocomial C. diff was included in there, although today we do know we have some community-acquired cases, right? And of course the neutropenic patients with all the infections that go along with that, including aspergillus and candidiasis. And of course, HIV-associated, and things to think about in this category are CMV, MAC, pneumocystis, pneumonia, and lymphomas and sarcoma, and Kaposi sarcoma. And I have a couple of different tables there. There's different tables with the divisions and within each category what you should think about. For example, infections, TB, especially extrapulmonary TB, abscesses, endocarditis, of course, is a big one. Viral infections, CMV and EBV. Of course, HIV is a big one. I work with this every day, so check your HIV tests on folks. Amongst the malignancies, leukemia and lymphoma are the big ones to keep in mind. Of course, autoimmune conditions are big too, and there are some other miscellaneous conditions, including drug-induced fever, factitious fever, which of course you've heard about, sarcoidosis. The next slide is a similar table. Here you're just outlining the percentage of, of these causes. So you see here infection accounts for 20 to 40% of FUOs, which is pretty similar to malignancy actually, and inflammatory disease 10 to 30%. Okay, so just keep that in mind. And we talked about drug fever. There's a lot of drugs that can cause fevers, and some of them are antibiotics, so also keep that in mind. The previous lecture was talking about cefepime and seizures, and of course you have cephalosporins in this category too. Penicillin is a big one. Cephalosporins we talked about, carbapenems, and anti-seizure medicines that you just heard all about those. So those are notorious for drug-induced fever. And even our non-steroidal anti-inflammatory drugs, so ibuprofen and salicylates, can cause a drug-induced fever. So how do you approach these cases? And there's several different algorithms out there, but the key to this is getting a good history. So your history is going to be the main thing you have to work on, because that's what's going to give you the diagnostic clues, as opposed to doing a big, huge workup without a focus, okay? So on this table, I hope you can kind of see it, but basically you start out with the definition, right? You first have to establish that there's a fever going on for a period of time. Then you go into your comprehensive history, and you're going to look for clues. And then if things point you in a certain direction, that's what you're going to go for. If you have a suggestion of endocarditis, an AICD perhaps, or something that points to an endovascular infection, obviously you're going to go after that. If not, if truly you've kind of looked at the big main things that you saw on those other lists and you don't have a clue of what's going on, then you start your minimum workup, which would include a CBC, an X-ray, a UA, and culture. Of course, you can do your inflammatory markers. Blood culture is always good, right? And then, of course, some serologic testing for some of the viral etiologies. HIV, always check an HIV, okay? And, of course, you're going to look into, depending on their history and exposure, you're going to look for screening for TB, okay? And then you kind of go down that. If you find evidence of something, you pursue that. If not, then you can consider other diagnostic workup for some of those non-infectious etiologies we talked about. This is just another algorithm trying to kind of separate what you would do for each category of, so for infection, what you would check, and then if you're suspecting malignancy, what you would check, and autoimmune disorders. So this is another, just a graphic way to figure out what to do and where to go with those patients. And this, it's hard to see, but this is kind of just a table giving you certain clues as to what you would think of. So, for example, if you have a history of freshwater exposure, or people who are homeless, or are walking around barefoot, you can't think of leptospirosis. Of course, crowded living conditions, homelessness as well, or living in a shelter should point you to TB, obviously depending on additional symptoms. So this is just a quick list of things that should prompt you to think of certain things. History of transfusions before the 1980s, you kind of think, Hep B, C, HIV, and psychiatric illness, you don't want to ignore them. You want to do your appropriate workup, but also think of factitious fever, especially if you're not able to really document. It's a lot of times patients who just come to you and say, I have a fever every day, but every time they're in clinic, their temperature is stone cold normal. Okay, so just keep that in mind. And of course, some rashes can point you in certain directions. Hepatosplenomegaly, you think CMV, EBV, leukemia, lymphoma. So that's just a list of some clues that you should look for when you're doing your history. So I'm going to go into cases and questions now. I didn't bring my eye clickers today, but we'll just kind of go through these so you can see what we come across. So in terms of epidemiology, what would you guys think is the most common cause of FUO in the developed world? Would you think it would be A, malignancy, B, infection, C, no diagnosis found, or connective tissue disease? It's like a show of hands. Like, who thinks it's A? What about B? Okay, what about C? Okay, and what about D? All right, so just from the hands, most of you got it correct. So the answer is actually C, no diagnosis. So this is based on what? This is based on several case series where they looked at these cases and saw where we got a diagnosis and where we didn't. So several different people looked at this, and like in this series here in Belgium, a third of 290 patients had no diagnosis. In this series, it was more impressive. It was 50%, so half of these patients in the Netherlands without a diagnosis. And in 2014, we had another series from Japan for about almost 30% of patients without a diagnosis. Now, what about this? In most series of cases of FUO from countries with temperate climates, what is the percentage of patients that had infection? And that we kind of looked at in that little other table at the percentage. What would you guys think? 10 to 20%, 20 to 30, 30 to 40, 40 to 50, 50 to 60. This question is kind of hard because I kept all the numbers very close together, but what would you guys guess? A, any takers? B, okay. C, okay, pretty split. D and E. All right. So the answer is actually 30 to 40%. So in a series where they looked at this, so in U.S., Western Europe, Japan, so temperate climates, it's 30 to 40%. The incidence seems to be higher in tropical and subtropical climates because you run into a whole host of different things. So incidence of TB, for example, is higher in these tropical and subtropical climates, and that's why you have a higher percentage of infection as causes of FUO. All right, so let's go jump into some cases. So this case is a 21-year-old female from Africa. She has over 4 weeks of intermittent fevers up to 101. And again, these are occasional. They're not happening every day. She has dysuria and hematuria. People have attempted to do a workup, so they've done the usual, a bunch of UAs with a culture. And all the UAs have white cells in them. They have pyuria. But when they do the urine cultures, all of them grow no bacterial. The routine cultures are negative, okay? From the history, start talking to her. You know she lived in a refugee camp for several years prior to coming to the U.S. So what would you guys think is the most likely diagnosis? A UTI, pyelo, or renal TB? Any takers for A? Okay, good. Any takers for B? No. Maybe. Okay, and what about C? All right, so this is a classic case, right? So if you have dysuria, sterile pyuria, and hematuria, that's like the classic triad for renal TB. But of course, what's going to point you that way? The history, right? We talked about being in a refugee camp. She has the right geographic exposure. So that's what makes you think of this. Typically, for extrapulmonary TB, in some other sites, you might have fever as a more pronounced symptom. In renal TB, that is not as frequent. It's just that the breakdown of the granulomas in the kidney can happen at different times, and you're not going to necessarily have a daily fever as you have sometimes with pulmonary TB, okay? But the clinical picture is what's going to tip you off, and of course, radiographic findings. So you're going to tend to see strictures and hydronephrosis. It's an insidious disease. It takes a while to do its damage. And the reason why your routine cultures aren't going to show you anything is because you need AFB smear, right? And even that is not very sensitive. So you really have to rely on your history and your radiographic findings and the clinical picture, okay? And we talked about systemic symptoms being less frequent in renal TB, but the key here is the exposure history and the clinical picture, okay? And this is just showing you a very tiny calcified kidney here, which you can see in these cases, all right? Okay, let's go to the next one. So this is a 47-year-old homeless male. He comes to the ER. He's disheveled and shoeless. And he has pronounced conjunctival suffusion, stiff neck, myalgias, transaminitis, and a high fever. What do you guys think is the most likely diagnosis? Would that be TB, endocarditis, conjunctivitis, or leptospirosis? Any takers for TB? Okay, what about endocarditis? Anybody buying endocarditis? No. Conjunctivitis, I hope nobody picks that one. All right. And what about leptospirosis? Okay, good. I put some very obvious buzzwords here, but they do like to ask you about this on boards and such. So conjunctival suffusion is supposed to be very characteristic of the early phase of leptospirosis. So that's what I was going for here. And then we also put some clues with clinical history, right? He's shoeless, right? That's one thing. I'm originally from Brazil, and a lot of times people walk around barefoot, and especially after a big flood or rain, you can have that. There's a lot of vectors for leptospirosis, including dogs. It does happen in dogs, rare in cats, but a lot of other like rodents, other small mammals are going to be vectors. So it's a zoonotic disease. And of course, this is caused by a spirochete, so it's a Leptospira species. Usually the symptoms we talked about in the clinical vignette, right, with the fevers, rigors, myalgias. Conjunctival suffusion appears in about over half of the patients, and it's not something you typically see in other infectious diseases. So that's why this kind of stands out. And it will look exactly like this. And you don't have, in the way you differentiate it from conjunctivitis is because you don't have the purulence, okay? So it's just a suffusion in the conjunctiva. And treatments for this include doxy, azithro, amoxicillin. Typically for severe cases, the treatment is about 5 to 7 days, okay? All right, let's go on to the next one. Yes.
How often do you see the spirochete under the...
I'm not sure about the percentage. I guess you would have to actually get the sample from there. I don't think people typically do that, but I don't know the percentage of how often you find that in there. Okay, so let's go to the next one. So this is a 35-year-old male. He's got fevers of 103, myalgias, arthralgias, and arthritis, and also leukocytosis. But then he reports this evanescent salmon-colored rash, especially when he's febrile. What is the most likely diagnosis? Is this typhoid fever? Is this an occult abscess? Is this adult stills, endocarditis, or CLL? Any takers for typhoid? Okay. Any takers for abscess? What about adult stills? Okay. Endocarditis and CLL? Okay, so there was a split between the two answers I would expect, which was typhoid and adult stills. The answer to this one is actually adult stills. So let's break this down. Why is this question adult stills? So the key there was the evanescent rash, because for those who picked typhoid fever, you do have salmon rash, right, rose spots. However, those are not evanescent. Evanescent meaning they fade away. So those stay there. This one is saying is very characteristic to say that they kind of fade away but come back when the fever's there. All right, so that's kind of why this was pointing you towards adult stills. So adult stills onsets between 16 to 35 years old. Fevers can be extremely high, even up to 107. And you can also have some other things with it, including splenomegaly, lymph node enlargement, and sore throat. And basically this evanescent rash is characteristic. And I don't know how well you can see back there, but this is kind of the picture. And you can see, like on the forearms, that's supposed to be a hallmark for this. All right, let's go on to the next one. What about this 52-year-old female who's coming in with headaches, decreased vision, fevers up to 102. Her ESR was high, up to 100, and she's got this tenderness to palpation in the right temporal region. Now, this is pretty obvious diagnosis, I would hope, but my question to you is what test is most likely to give you the diagnosis, which should also be pretty easy for you guys. So are you going to LP this person? Are you going to do a temporal artery biopsy? Are you going to MRI her? Or are you going to do a CT? Any takers for an LP? No? Okay, good. Any takers for the imaging of the head? No. Okay, so duh. All right, duh. This is temporal artery biopsy, right? So I'm talking about giant cell arteritis, right? So this usually happens in people older than 50, and your ESR is typically higher than at least 40. And you can have a constellation of symptoms. So headache is a big one, sometimes jaw claudication. Visual loss is the big thing we worry about. That's why you want to make that diagnosis as soon as possible. You can have sometimes lower back pain and large proximal muscle pain, scalp tenderness, and you can feel the temporal artery, like it's palpably abnormal. Some people have elevated LFTs, but mainly your diagnosis is the temporal artery biopsy. And the treatment's high-dose steroids, especially because you want to prevent them from having that visual loss, okay? But that is a classic question for FUO, you know, that is pretty classic, and you guys were all very aware of this diagnosis. All right, so what about the most common neoplastic cause of FUO in most series? So this is going to be a guessing game, right? So do you guys think it's renal cell, gastric, bronchogenic, lymphoma, or leukemia? Who's up for a renal cell? Is that something that you would think is the most common cause of neoplastic fever? Nobody. Okay. What about gastric? Anybody? No. Bronchogenic? No. What about lymphoma? All right. And leukemia? Okay. Very good. So yes, the answer is lymphoma. In both Hodgkin's and non-Hodgkin's, you can see a daily temperature elevation. And one thing that they might want to ask you about is this relapsing fever. So this is a cyclical fever that increases for over 1 to 2 weeks and then decreases and then increases again. And that's called Pell-Epstein fever. And that's occasionally described, especially in Hodgkin's lymphoma. So you might have a question about that. All right, what about the 70-year-old male who has FUO and has pancytopenia? They look at his peripheral blood smear, and you have macrocytosis, poikilocytosis in the RBCs, and these Pelger-Hewitt anomalies in the neutrophils. So what's the most likely diagnosis here? Do you guys think it's Castleman's, large cell lymphoma, malignant histiocytosis, AML, or myelodysplasia? What would be the most likely with this constellation of findings? So any takers for Castleman's? No. What about large cell lymphoma? Malignant histiocytosis, AML, or myelodysplasia? Oh boy, nobody wanted to answer this one. But I got, okay, that's fair enough. So let's talk about this one. So this is myelodysplasia. And myelodysplasia is actually a group of several hematologic disorders, but typically happening in people who are over 50. So you have abnormal proliferation and differentiation of the stem cells. So you can have a constellation of things going on. So anemia, leukopenia, and thrombocytopenia are common. Fever will be the major constitutional syndrome in this case, okay? And what about the peripheral blood smear? So let's break that down. So you can have macrocytosis, so the RBCs are big, right? Poikilocytosis, which means that they are have an abnormal shape to them, right? Like they almost look like a multi-tiered star, almost like a spur cell, but not quite. And anisocytosis, basically the RBCs are of different sizes, right? And this is something else that they talk about, this Pelger-Hewitt-like anomaly, where your neutrophils are hyposegmented, because typically you want 3 or more lobules in the neutrophils, right? And here you can see that most of them just have 2. So that's another anomaly that you see in myelodysplasia. All right, what about this one? This is a 55-year-old woman who has FUO, and she develops these purplish nodules and plaques over her face and neck. What do you guys think this is? Non-Hodgkin's, Castleman's, and then there's Kikuchi's, and Schnitzler's, and renal cell carcinoma. And I promise you, some of these things actually exist. So any takers for non-Hodgkin's? What about Castleman's? Kikuchi's? Anybody? No. Schnitzler's? No. Renal carcinoma? Anybody? Okay, one person. Okay. All right, so this is actually a non-Hodgkin's, okay? So this is a peculiar manifestation, like a skin manifestation of non-Hodgkin's. And you can develop these very big, pronounced, purplish, it can be nodules, papules, plaques. And usually it's on the head, head, neck, and scalp. And this was actually reported as a manifestation of diffuse large B-cell lymphoma. I am going to run through the other funny names we saw in there, just so you believe me that this actually exists. So Kikuchi's is a necrotizing lymphadenitis. I actually had a case of this when I was a resident many moons ago. And this is a benign condition, and you have cervical lymphadenopathy and fever. And the way to make this diagnosis is through biopsy, okay? Luckily, this is benign, and you don't really do anything for it, but you biopsy it to know what it is, okay? And Schnitzler's is actually a condition where you have chronic hives and periodic fevers. It is also benign, nothing to do for it, and you find a monoclonal gammopathy, all right? So if you see a question that talks about hives and fever, that's what they're talking about. And Castleman's, of course, I'm not going to go into the full details of it. Most of you have looked through this before, but this is an angiofollicular lymph node hyperplasia, and there's two different types, the unicentric and multicentric, affecting multiple organ systems. And a lot of times it's associated with some viral infections and malignancy. Viral infections including HIV and HHV8, and different types of malignancy are also associated with this. All right, let's go to the next one. There's a 35-year-old male, and his fundoscopic examination reveals perivascular sheathing, also described as candle wax drippings. And he also has an elevated serum alk phos level. What's the most likely diagnosis? Anybody think this is non-Hodgkin's? What about sarcoid? Okay, got some takers. Giant cell arteritis. Anybody? What about bronchogenic carcinoma? No? And endocarditis? No. Okay, good. Well, for those who answered, most of you answered sarcoidosis. And several vasculitis have like the cotton wool spots and intraretinal hemorrhages due to vascular occlusive disease. But for sarcoid, this candle wax dripping is very characteristic and kind of looks like somebody just took a candle and dripped it all over there. And you can also see choroidal nodules. So these two findings are specific for sarcoidosis. So if you see a question talking about candle wax drippings, that's what they're talking about. And okay, let's go to the next one. Okay, this is one of my favorites. All right, so a 40-year-old male comes in with HIV infection. His CD4 count's very low, below 100. He develops a protracted fever and skin-colored umbilicated nodules on his trunk. The most likely diagnosis is disseminated cryptococcus. Any takers for that? Okay. Kaposi's. Anybody? What about histo? No. Disseminated MAC. Okay. And what about pneumocystis? Okay. All right. So the answer to this, so this is a tricky question. So the answer to this is disseminated cryptococcus. So let's just break down the different appearances for these different things in an HIV patient. All right. So blasto, you see more of a verrucous growth. It's like kind of crusted over. This is characteristic. Okay, so it's not the umbilicated center that we talked about. Histo, you can have skin lesions with histo. They're not typically umbilicated, and there's a predominance for oral ulcers. Okay. Now, crypto can present differently in immunocompetent and immunocompromised people, and that's the point I'm trying to make here. So in the immunocompetent, it looks more like erythematous papules. Sometimes you can have some cellulitis or sub-Q nodules and pustules. However, for some reason, in HIV-positive patients, it's more a skin-colored nodule with that central umbilication. I avoided putting molluscum in there so it wouldn't become confusing, but it is similar to molluscum. but the lesions tend to be bigger. But that is characteristic of cryptococcal lesions in an HIV-positive patient, okay? And this is Coccidia Nodules. So, oh, my bad. This thing is sensitive. The Coccidia nodules do not have a central umbilication. They're kind of more weepy and sometimes present more abscess-like. So different from the verrucous appearance of the blasto, and no central umbilication like you see with the crypto. And again, to emphasize, this would be crypto in HIV-positive patients. Okay. All right. Now let's look at this question about drug fever. After discontinuing the responsible medication, in nearly all cases of drug fever, the fever will abate within any takers for 6 hours. No, how about 6 to 12 hours? Okay. 24 to 48? Okay. What about 48 to 72? Okay. Yeah, the C and D is kind of unfair. It's very close together, but the correct answer is actually 48 to 72 hours. All right. So this, we went over a slide in the beginning where we had all the different classes of medications that can give you a drug fever. So you know that this can occur with pretty much any medication. It can occur in any time period. It doesn't have to be right when you started it. So some people are on this medication for a long time and they have a drug fever. 20% of cases have eosinophilia and a rash, so the eosinophilia might be a tip-off for you. It can mimic bacterial sepsis sometimes, but the fever pattern is rarely distinctive. A lot of times you hear people say, oh, I didn't even know I had a fever, you know, and that might point you to that. But basically, your fever does abate within 48 to 72 hours of discontinuation. I actually had a patient when I did primary care who was on mesalamine for ulcerative colitis. I can't remember which it was. But she had been on that for 7 years and all of a sudden started having these daily fevers. And she wasn't, like, cultures were all negative. You know, we did an echo and all this stuff. And finally I was like, well, it's got to be the mesalamine because there's nothing else going on. She was otherwise completely well, but would have these drenching sweats at night and fevers to 103 even. So we did stop the mesalamine, and the fever did abate after 72 hours. And, you know, you can confirm your diagnosis by rechallenge. I did not want to rechallenge her, but in case you want to do that. So that is drug fever. All right. What about this one? This is a 65-year-old female who has fever and an erythematous eruption. She has macules and papules all over her trunk and extremities while she was receiving some amoxicillin for a UTI. Despite stopping the amoxicillin, the rash and fever persists for several weeks, and she starts having enlarged axillary and cervical lymph nodes. What's the most likely diagnosis? Do you guys think of Castleman's? Anybody? What about a drug fever? Okay. Hodgkin's lymphoma? Okay. What about angioimmunoblastic lymphadenopathy? All right. And what about Kikuchi's? What do you think of that? We talked about that a little bit, right? Okay. So let's see what the answer is. Actually, angioimmunoblastic lymphadenopathy. And hopefully they won't ask you this on internal medicine boards. They sometimes like to ask this on ID boards. So this is an entity that happens around the 6th or 7th decade of life, and you have diffuse lymph node enlargement with some hepatosplenomegaly, and you can have a rash. And unfortunately, a lot of times it seems to begin as a hypersensitivity reaction to a medication. So the key here is to note that it's not a drug fever because, we discontinued therapy, but the fever persists over several weeks. So remember we talked about drug fever, your fever should go away within 48 to 72 hours, right? And then I guess with Kikuchi's, you would expect a more localized cervical lymphadenopathy. You don't typically have axillary lymphadenopathy, and that's why you wouldn't choose that. So that's just something to keep in mind. I don't think they're going to ask you about this. All right, what about this guy? He's 68, daily fevers for 3 weeks. The fever first occurred after some back pain that seemed to travel into the upper abdomen. And then the pain kind of went away over the next 6 hours. When they looked at his lab blood work, what did they see? They saw a crit of 34, an MCV of 80, and a blood smear looked fine. What do you guys think this is? Any takers for myelodysplasia? No. Leukemia? Anybody? Dissection of the thoracic and abdominal aorta. Okay. What about lymphoma? And giant cell arteritis? Anybody? No. Okay. So the answer to this one is the dissection. Okay, so I wanted you guys to also think about other things that are not autoimmune and are not infectious, right? So the crit being low and this pain that's going up, you know, that's all suggestive of a dissection. So you have to keep that in your mind. And you all know that wherever blood accumulates anywhere, that is always a source for a fever, right? So basically this is a dissection. You have hemorrhages into the abdominal cavity or retroperitoneal space. You can have bleeding within the wall of an aneurysm. And you can, with a dissection, you can have persistent fever and anemia following this episode of a sharp, you know, back or chest or pain that then goes away, because then, you know, it was hurting, but then now it's burst, so it subsides. All right? All right, let's look at this guy. He is a 58-year-old man who has daily fevers for a month and then develops visual loss in his right eye. When they do a fundoscopic examination, there's a choroidal mass, and a careful skin examination shows this cluster of firm, non-tender, movable, skin-colored nodules on his left upper thorax. What is the most likely diagnosis? Do you guys think this is Hodgkin's? Anybody? What about bronchogenic carcinoma? Okay. Pancreatic cancer? Sweets? Or renal cell? Nobody liked this question. All right. So this is actually bronchogenic carcinoma. The point we want to make here is that you can have cutaneous metastases of bronchogenic carcinoma. And it's a lot of times in sites of previous biopsies or radiation. So you usually see sub-Q or cutaneous nodules that are mobile, firm. They're described as rock hard. That's what the guy had. They're painless, skin-colored. Sometimes they can take on different colors, purple or brown, and appear in clusters. But you also have to keep in mind that you can have cutaneous metastases, and these can be associated with fever too. So cancer is a big one when you're thinking about FUO, all right? Especially when you start seeing lymph nodes that are rock hard, that's bad, right? All right, I think those were all the cases I had for today, but I would like to emphasize that the key here is truly your history. Your history is going to be 95% of managing and diagnosing an FUO. If you don't get that good history, if you don't ask where they traveled or if they have pets or if they drink unpasteurized goat milk, you're not going to make your diagnosis, okay? Of course, you could always start scanning and culturing and doing all this stuff, but sometimes if you do not take the time to get a good history, you're not going to go anywhere.